Hello, everyone. Thank you for joining me tonight. My name is Dr. Joe Heston. I'm one of the chiropractors at Ames Spine and Sport. And today we're going to talk about what I like to call Arthritis 101, which is basically discussing the different types of arthritis that people can develop. And I'll kind of explain why. I think it's important to at least be familiar with the different types. But just a little quick kind of review of what we're going to be doing here. First is my disclaimers. So this presentation is just for educational purposes. Please don't self-diagnose yourself or self-diagnose others. You still need a board-certified physician in order to make a lot of these diagnoses. And again, this presentation is covering the basics, just like the most common ones and most common presentations, but there's a ton of different types of arthritic pathologies, and even the ones that we'll cover here tonight, there's different subsections and subtypes and atypical presentations and things like that that would just take hours and hours to go through every single one. So we're just going to kind of hit the main ones here and talk about what classically is associated with each one. So first question you're probably asking is, well, as the patient, why do I care? Isn't that your job to kind of know what to do? And to an extent, that's totally true. But the key thing, and at least being familiar with a lot of these, is that it allows open communication between the healthcare provider and the patient. And the main thing I kind of focus on is just being familiar with what I would call learning the language. Each profession, doesn't really matter what it is, has kind of their own terminology in how they communicate with other people within their profession. My brother is one of my brothers is a CPA, and there's certain lingo and acronyms and things like that that CPAs know that they kind of communicate with each other back and forth. But if he starts throwing it at me, I have no idea what he's talking about. And my dad was a mechanic, and it's the same thing with him. Where if he starts talking about distributors and different types of double overhead cam and things like that, I might kind of recognize the words, but I have no idea how to fix it and no idea what he's talking about. So at least having somewhat of a knowledge base in terms of either the anatomy or the arthritis can kind of help both of us out in the long run. Main thing is that it helps me in terms of not thinking or misdiagnosing something you might potentially have. And the classic case is someone comes in and says, "Oh yeah, I have a family history of arthritis," and a lot of times people think, okay, maybe they're talking about rheumatoid arthritis, and then we start ordering lab tests and X-rays and MRIs and serology and blood work and things like that, and it all comes back as totally normal, or it just comes back as osteoarthritis, which again, not life-threatening. It's definitely treated differently than rheumatoid. It just kind of allows us to kind of better serve you and allows you to better serve yourself and allow better communication, not just with me and Dr. Jesse, but with all your healthcare providers. Because as long as everyone's on the same page, everyone should have an optimal outcome. So kind of what we're going to focus on tonight, and again, this is just kind of the basics, bare bones, if you will. We're going to talk about kind of some normal joint anatomy stuff because it's kind of hard to talk about pathology and different conditions without first understanding, well, what is a non-pathologic or what is a normal joint. And then the main ones we'll talk about, and again, these have different names or synonyms associated with each one. So I'll try and cover all the different synonyms, but some of them have like 6, 7 different names that are all essentially talking about the same condition. So it can get a little kind of confusing and overwhelming there, but I'll try and keep it fairly straightforward for everything. But the most common one we'll talk about and that you're likely to see is osteoarthritis. It's kind of the big one that everyone thinks about. A lot of times when patients talk about how, oh, I got diagnosed with arthritis, or my mother had a history of arthritis, or my dad has arthritis, this is usually what they're referring to as osteoarthritis. And it creates a lot of confusion because the ending itis, in terms of medical kind of dictionary, usually implies inflammation. And that's kind of a misnomer because osteoarthritis, although it can produce some mild inflammation, it's not the same amount of inflammation that really we attribute other conditions that end in itis, like appendicitis, meningitis, encephalitis, things like that, where it's just almost like an infection or just an overwhelming amount of inflammation. I mean, the inflammation we see with osteoarthritis is pretty minimal. Which is why a lot of times they're trying to avoid using the term osteoarthritis or OA, and they're trying to come up with something that does not have itis. And that's where we get degenerative joint disease, degenerative disc disease, and discogenic spondylosis and things like that I'll kind of go into a little bit later. But then, rheumatoid arthritis and juvenile arthritis and spondylitis, those three are definitely very inflammatory conditions. So in that case, the name arthritis actually, or itis, is very appropriate. But then gout and CPPD can both produce tremendous amounts of inflammation as well, but they don't have the itis. So again, it can get very confusing and very overwhelming at times, but we'll keep it fairly straightforward for you. And then if you're like me and you tend to zone off from time to time, and then all of a sudden you realize you're at the end of the presentation and you have no idea what just happened, I got a nice little review table at the end here that should kind of help put us all on the right page and help make things a little bit more clear, especially if you're a little bit confused kind of midway through this. And then here's just kind of a little picture I have for you. Just, I'll go over the normal joint on the next slide, but just kind of what we normally expect to see the joint, what we see with osteoarthritis. And right away, you can kind of tell just by looking at it how there's definitely significant differences in looking at the normal joint versus the joint due to osteoarthritis versus the joint due to rheumatoid. Probably the first thing you notice right away is, well, how come it's fused right there, but it's not fused in the osteoarthritis, and it's not fused within, the healthy joint. And that's because that's one of the important key distinctions is that osteoarthritis does not usually produce enough inflammation that will actually cause bone to be deposited between the joint, leading to fusion. It can in very, very severe cases, but generally as a rule, it does not. Whereas an inflammatory arthritis like rheumatoid or like ankylosing spondylitis, it's very common to actually get so much inflammation around this joint that we start depositing bone around it and it leads to an eventual fusion. So when it comes to normal joint anatomy, and joint is an extremely fairly loose term for essentially any place in the body where you have two bones meeting to articulate. And when most people think of joint, they're talking about a specific type of joint called the synovial joint, which it's the main type in the body. It's what we see in most movable joints, like our fingers, our hips, shoulders, knees. Most joints that we can readily move fairly easily are classically synovial joints. And it's called the synovial joint because it has a structure within it called the synovium. But there are different joints in the body that do not have a synovium and actually still form technically a joint even though it doesn't move. And like the classic examples we talk about are, if you look at a baby, they actually have kind of holes, for lack of a better term, within their skull called fontanelles that just represent islands of cartilage that as they grow older will eventually transition into bone until you have just what seems like one solid chunk of bone that makes up your skull. But really the skull is made up of different kind of islands of bone that form articulations with each other. And a lot of times if you look at either an x-ray or CT, you can see where those different bones actually meet and articulate with each other. And while they don't necessarily move like our fingers do, it's still a place where you have two bones kind of meeting to join with each other, and it's technically a joint. And then the same with the teeth, technically where the teeth are actually inserted into the lower and upper part of your mouth and jaw, the mandible and the maxilla, that's technically a specific type of joint called a gomphosis. Again, doesn't really move or anything, but it's still technically a joint. And while you usually don't get arthritis there, it potentially could be one spot, it's just not very common. And then within the spine's a little more complicated because we have synovial joints and we have non-synovial joints within the spine. So the back part of the spine where we have kind of facets that allows us to relatively move from side to side and kind of rotate a little bit, that's primarily due to the actual kind of synovial part of the facet. Whereas where the disc is, that's a non-synovial joint. So you'll have different types of arthritis that'll affect the front part of the spine where we have our intervertebral disc and our vertebral bodies. But then you can also have a different type of arthritis that can affect the back part of the spine where we have the synovial portion around the facet. So even though it's technically the spine, you can have different types of arthritis affecting different locations, even within the same patient. And then again, that's where it gets kind of muddies the waters a little bit. But for this presentation, we're going to focus primarily on the synovial joints, but near the end, I'll talk about a specific type of arthritis that'll affect synovial joints and the joints within the spine that are non-synovial. So when it comes to actually figuring out what type of arthritis a person has, it's not really as cut and dry as a lot of people believe it to be, where it's just, oh, you have pain at this location, or, oh, your x-ray actually shows, these findings at this spot, it's just this arthritis. There is a tremendous amount of overlap, especially between the different types of inflammatory arthritis like rheumatoid, lupus, ankylosing spondylitis, enteropathic, reactive. I mean, there's a ton of overlap. And something like gout or an infection can mimic a lot of different types of arthritis. So to try and figure out what specific type you have or someone is having, you really need a combination of many clues. And as long as those clues are relatively pointing toward one specific arthritis, you can definitely hedge your bets and start eliminating or including different types of arthritis. So when I approach this, first thing I want to determine is location. And I mean specifically within the body. Is it affecting the small joints of the hands and fingers? Okay, well, that usually implies something inflammatory like rheumatoid. Whereas, is it just involving one joint and it's the thumb? Or excuse me, one joint and it's the big toe? Okay, well, that usually implies something like gout. Or is it involving pretty much the low back joints, and especially some of the hip joints, and like a younger person, like a boy, that usually implies something like ankylosing spondylitis. So location is a key, and then if it's involving just like one hand, or if it's involving both hands, or one knee versus both knees, that's another kind of clue as well. Clinical findings, mostly in terms of, is it asymptomatic where really they don't have any pain there? We took an x-ray or we were looking for something else and we just happened to see it. That's an important clinical clue. Do they have something like a fever or a rash? Because if they have a fever or a rash or inflammatory bowel disease like Crohn's or ulcerative colitis, that could kind of lean toward inflammatory arthritis like rheumatoid or ankylosing spondylitis. Whereas if they really don't have any of that, then we kind of lean back toward just osteoarthritis. And then genetic or kind of familial influences in terms of patients that have rheumatoid are likely to have a primary relative with a history of rheumatoid, especially if it's a primary relative like mother, sister, aunt, grandmother, things like that. Whereas other types of arthritis tend to just be multifactorial. And my dad was a tractor trailer mechanic, so after doing that for 25, 30 years, he's beaten up a lot of his body. So he has degenerative joint disease in a lot of his joints just from the repetitive toll of being a tractor trailer mechanic. Whereas other conditions like rheumatoid have a risk factor associated with smoking and obesity. So things like that as well. And then gout usually is due to a poor diet and obesity as well, especially in males. So kind of linking all that together. And then blood work is also very helpful in terms of if we can kind of figure out if it's one arthritis type versus the other, blood work will often be, very critical to helping us out. And like the classic case, which we'll talk about in a sec here, is when you're suspecting someone has gout, but then you order blood work on them looking for high uric acid levels, and the uric acid levels are actually normal. That's when you have to start backpedaling, thinking, okay, well, if it's not gout, maybe it's the thing that mimics gout, which would be pseudo gout. And that's also known as calcium pyrophosphate deposition. But you kind of need all these pieces together to start to get an approach of which type of arthritis we're dealing with. And then other pertinent information that I also like to know is there any history of trauma or surgery? And that's mostly true, especially for something like degenerative joint disease or osteoarthritis, where it likes to affect specific joints. But if it's in an atypical location like the elbow or the ankle, where usually it doesn't occur there, but then the patient or someone will acknowledge like, oh yeah, I broke my ankle skiing 2 years ago, or yeah, I dislocated my elbow 4 years ago, at work or something. That can kind of help give me more credence to thinking it's a certain type of arthritis. And then certain medications and supplements are notorious for causing certain types of arthritis, especially, or even just looking at their medication list and saying, okay, you're on anti-inflammatory medications. Why do you have that? And they're like, oh, I have psoriasis. And there's a certain type of arthritis called psoriatic arthritis that manifests from psoriasis. So it's kind of getting clues like that can definitely help long term. And then the hand is also a great way to kind of help figure out what type of arthritis we're doing. So a lot of times when patients have hand pain, we'll kind of start with x-rays too. And again, if it's in specific locations, that really gives us kind of a channel or which avenue we want to travel. So a lot of times, if you look at the blue here, this is known as your dip or your distal interphalangeal joint. It's the joint of your hand or of your fingers that's closest to your fingernail. And something like OA loves to live there. while rheumatoid usually does not. And if you compare that to the green down here, which is your MCP or metacarpal phalangeal joint, this is basically where your fingers kind of attach onto your palm. And something like OA usually does not like to live here, but other things like rheumatoid, gout, or excuse me, pseudo gout really like to affect here. And being able to kind of figure out which locations are being the most heavily involved can, again, help us try and figure out, should we go down the inflammatory arthritis path or should we go down the osteoarthritis path? All right, so the first one we'll talk about here is just osteoarthritis. And again, this one is very, very common. And unfortunately, it has a lot of different names with it. So, kind of the more common ones I think people are familiar with, other than osteoarthritis, are DJD, degenerative joint disease, or if it's osteoarthritis of the spine, they'll sometimes call it degenerative disc disease or DDD. Some people just refer to it as like a wear and tear type of arthritis, showing that it's really a manifestation of like mechanical stress over the years. Another name, unfortunately, is if it's in the spine, they might just call it discogenic spondylosis. And again, they're coming up with all these names because they're trying to avoid the term osteoarthritis, because the itis at the end implies that it's an inflammatory condition. And while there is some inflammation, it's nothing compared to the inflammation we see with rheumatoid and other types of inflammatory arthritis. This one tends to increase with age, so usually can start technically at any age, but for me, I kind of think 25, 30 and over. But again, if someone had a history of a fracture, or if someone had a history of like a dislocation or something, or another kind of muscle or tendon injury, that can actually lead to early onset osteoarthritis. So it can generally span in 20s on over. It's kind of what people will generally say, but usually I think adult and older. And again, this is multifactorial. It could be due to primarily in occupational stuff where you have a specific job where you're just beating up your joints every day. It could be due to you have another kind of underlying condition like calcium pyrophosphate deposition that's leading to early destruction of the joint. It could be that you were a football player, you tore your meniscus or you tore your rotator cuff, and it was never properly treated, and now it's leading to early onset degeneration as well. There really is no male to female prevalence with this. It can affect either one fairly equally. And that's kind of an important distinction in the sense that osteoarthritis really doesn't matter, but things like rheumatoid usually affects females more, but then other things like ankylosing spondylitis is pretty much only in males. So important distinction there. And then with OA, it tends to spare some joints unless they've had some sort of trauma or some sort of injury to that joint. Like the classic case is your ankle or your elbow. Those are joints where, as long as you don't cause any damage or injury to them, then you shouldn't get any osteoarthritis there. Whereas other conditions like rheumatoid, they really like to attack the ankle or the elbow. So that's kind of an important clue. Oh. And then if we look at kind of the actual image here, so on your left side here, that's kind of what the normal joint we would expect to see. So the white part is the bone, the pink part is the cartilage, and then that blue line is kind of part of the synovium itself. And inside, kind of that darker gray shade here, that's just the normal synovial fluid. Well, over time, either due to dehydration or abnormal biomechanical stress, we can actually cause this cartilage to deteriorate and the loss of fluid within the joint. As this joint loses fluid and loses cartilage, you'll actually get narrowing from one side of the bone to the other, referred to as joint space narrowing. And as this occurs, this can cause the joint to be kind of sliding around a little bit back and forth. And that sliding around will actually kind of yank on the outer part of the synovium where it attaches to the bone. And the body will intuitively try and reinforce this area by depositing bone around this attachment in order to try and give it some more stability. And that deposition of bone is known as a bone spur commonly, or the more technical term is an osteophyte. But when you start seeing kind of bone spurs or osteophytes and this kind of loss of joint space, that's like a classic feature of osteoarthritis. Some more kind of clinical pearls to be aware of is that it's often described as a gradual onset stiffness. Eventually it can be painful, but usually it'll start off as, yeah, it just feels kind of stiff. It's not moving as well as it used to be. And then you might notice some occasional swelling. It's traditionally seen as worse in the morning, so you go to bed fine, When you wake up, you just notice the hands or your knees are just a little bit stiff. Sometimes you actually hear snapping and crackling, known as crepitus as well. But you notice that once you get up and start moving around and kind of walking and things like that, that the stiffness and the pain should relatively go away fairly easily, especially if you're really moving around. And that's like a classic feature of osteoarthritis. Whereas some of the more inflammatory arthritis is like rheumatoid or ankylosing spondylitis is, yeah, eventually as you move around more, it should get better, but it takes, midday, late in the day before you finally start to feel some of that stiffness and pain go away. Whereas osteoarthritis is relatively, even within the first couple hours, it should feel a lot better as you move around. Sometimes you can also notice these little bumps around specific joints in the fingers, and those are also known as nodes. And at specific location, they got specific names associated with them. But if you got these little bumps, and I know everyone's probably looking at their hands right now trying to see if they can find any, but if it's the joints closest to the fingertips, that's usually a bump that we associate with osteoarthritis. Whereas if it's closer to kind of where your fingers go into your palm, that's more so that we see with something like rheumatoid. And again, if you don't do anything for it, it tends to get worse. And these is the one that really responds well to conservative treatments. A lot of other types of arthritis, we talk about how we need some co-management between, chiropractors and rheumatologists, or if it's involving other areas of the body, some sort of kind of group effort. But OA tends to respond, very well, especially if we can catch it fairly early before it starts causing, severe arthritis or, fusions and things like that, although not as common as something like inflammatory arthritis. So key locations, we've kind of touched on most of these already, but think weight-bearing joints other than the ankle. So knees definitely bears a lot of weight. Hips definitely bear a lot of weight. Certain regions of the spine especially, so kind of lower spine where it goes into the pelvis, that's a common location to get it. Kind of where the thorax kind of goes into the upper lumbar spine, it's pretty another common location. And then kind of mid to lower neck is also another common location. We talked about in the hands as well, kind of the distal joints within your fingers, but also the base of your thumb. And then in your foot, usually around that first big toe. And sometimes you can get such severe osteoarthritis with kind of deviation of that toe toward kind of the outside of the foot that you end up getting what they refer to as a bunion. So could be due to other things, not specifically OA, but OA is potentially one cause of kind of a bunion at that location. And then the workup for this, there's really no need for workup. I mean, if you can see it on the x-ray, that pretty much kind of confirms what it is, as long as it's not in an atypical location or in an atypical patient. So if I had a patient come in that was like 12 years old and I took an x-ray because he was having ankle pain and he had severe findings of degenerative joint disease or osteoarthritis, that tells me that there's something else going on. Either he had some sort of severe ankle trauma and now he's getting secondary arthritis, or he has an underlying condition like hemochromatosis or something that we're not going to talk about, but there's something else going on here. But it's usually readily seen fairly easily with x-ray. And again, if we look at these couple examples I have here, so here's the actual knee. So this is kind of the femur is essentially your thigh bone, and then your tibia is your lower leg bone. Right, if we go farther down, it'll eventually go and form your ankle. But if we look at these joint spaces here, which is kind of the end of the bone to the other end of the bone, that's the joint space. At the knee, it should be roughly the same from side to side. And here, as you look at it, you can probably notice that, well, there's a lot more space over here than there is over there. So that's that loss of joint space that we talk about that represents destruction of the cartilage from wearing and tearing. And then if you look over here, we have that nice kind of bone spur, or kind of almost looks like a little spear coming off that end of the bone, and that's the osteophyte. And this appearance at this location is like a classic finding, especially in an older person, like adult and older, just classic osteoarthritis. And then if we look at this case in the hands, again, we kind of have that little bit of a deformity, which you could get with rheumatoid. But again, rheumatoid is going to prefer these joints down here and the wrist joint where we actually have the fingers going into the palm and where the arm goes into the hand. And kind of the base of the thumb as well is what you could see with rheumatoid, but you could also see with osteoarthritis as well. And if you look at the x-ray, again, we have that loss of joint space, those little kind of bone spurs kind of sticking out right there, just classic features. So what can we do for these? Well, there's a number of things we can do, and main thing is modification of activities, trying to avoid certain movements or certain activities that is going to lead to any biomechanical stress within the joint. So, like a classic thing with knee arthritis is a lot of times patients that have knee arthritis, that clicking and popping you hear is your kneecap essentially sliding in an abnormal spot against your thigh bone or your femur, and that's usually due to a weak kind of inner thigh muscle called your vastus medialis oblique. So we can retrain you through exercise or through electrical stim to reactivate that muscle to try and get it to pull the kneecap to its correct spot, so it's not jamming against the outside of the femur, creating that kind of clicking and popping. But supplementations, including omega-3, glucosamine helps attract water. So it goes to the cartilage in the knee, attracts water to try and help kind of balloon it up a little bit. But if you're on blood thinners, that's one specific contraindication they talk about is taking glucosamine while on blood thinners. But curcumin is a great anti-inflammatory. Pretty much with any inflammatory arthritis, a lot of times we'll recommend curcumin and collagen. I actually had a patient when I was a student at Palmer who had psoriatic arthritis, and he was on other medications for the psoriatic arthritis, but he told me firsthand that if he didn't have like his curcumin, he used to drink curcumin or turmeric tea, he could tell because all of a sudden he'd get a flare up even with his medication. But with the curcumin, the medication, and kind of I was adjusting him and stuff, he actually was doing quite well. But there's again different things we can do for this. Chiropractic wise, acupuncture, PT, massage, hot cold packs, all these have shown to be very, very beneficial to patients with osteoarthritis. Okay, so now we're going to go on to rheumatoid, and this is kind of the big one in terms of not calling rheumatoid osteoarthritis because with any condition, you want to diagnose it as soon as you can before it starts causing problems later down the road. And with rheumatoid, it's technically an inflammatory arthritis and an autoimmune condition. So the body's own immune system is attacking it. And since you have these immune cells in the blood, anywhere you have blood going to whatever structure, it could potentially lead to attacking that structure. So rheumatoid not only can affect the joints, it can affect the lungs, the heart, the eyes, just other organs. So the longer you misdiagnose this or the longer you delay treatment, the greater problems the patient's going to have further down the road. So it's important to diagnose this correctly as soon as you can. What happens in these patients is that our immune cells start attacking the part of the synovial joint called the synovium. And as it attacks this, it creates all this kind of inflammatory tissue called granulation tissue, also known as pannus. And as this pannus forms, it's going to start eroding and eating away both at the synovium itself and the structures nearest the synovium, which would include the bone within the joint and the cartilage within the joint as well. So that pannus is going to eat away, it's going to produce lots of inflammation and give us that characteristic swelling that we see around the fingers. Very, very painful. And if it goes misdiagnosed or untreated, it can lead to such severe destruction that essentially it leads to fusion, in which case then you can no longer use that joint because now it's just one solid bone instead of two separate bones connected by a joint. So some quick facts about rheumatoid. This one actually prefers females, which is different from osteoarthritis in that it didn't matter if it was male or female, but it's almost 2 to 3 times more common in female. There is a genetic or familial component in that if you have a primary relative, namely sister, mother, grandmother, with a history of rheumatoid, it increases your risk for developing it. But there are other things that also increase your risk, including smoking and obesity. This one will begin a little bit earlier than osteoarthritis, and that begins kind of 30s, 40s. But I've seen patients, early as, 22, 23 that already started to show symptoms as well. And this one, like specific joints, including the small joints within the hand and the wrist that we kind of talked about a little bit before. And a lot of times it'll actually hit both hands at roughly the same time. Whereas osteoarthritis usually will only hit one unless you're doing something where you're causing kind of a similar amount of trauma or some type of repetitive motion to both hands. But usually it's like the dominant hand, especially. And again, it can involve other tissues as well. So this is one of those things where, we can certainly help and treat part of the rheumatoid, but we're going to need help from other providers as well, especially like a rheumatologist. Or if they're having visual problems, we're going to get an ophthalmologist. Or if they're having cardiac or lung problems, then we need to bring in a cardiologist or a pulmonologist as well. So with rheumatoid, some of the obvious clinical features we talk about are we can see those nodes that we talked about with osteoarthritis, but again, the nodes that we're going to see are mostly going to be at the joints where the fingers start to go into the palm. And that's different because with osteoarthritis, it's going to be at the more distal kind of joints closest to our fingertips. And then the deformities that we see, you can see sometimes with osteoarthritis, but with rheumatoid, it's more obvious and it's going to classically result in the fingers being directed toward the inner part of the hand, kind of closer to the inside of your wrist and away from your thumb. And when it deviates like that, it's referred to as ulnar deviation. And while there's other types of arthritis that can do this, the main thing people think about when they see this is rheumatoid. It can also cause your thumb to really kind of bow backwards almost toward the wrist, otherwise known as hyperextension. And that's kind of known as a Boutonniere's deformity. And it can get really weird deformities kind of within your fingers as well. And if you look at certain people that for sure have rheumatoid, their hands can give, very unusual deformities. The pain and swelling that we see in these patients is more severe than what we see with osteoarthritis. I mean, any movement at all can sometimes just be excruciatingly painful, especially first thing in the morning when everything's been kind of still all night and it's just everything just feels locked up in these patients. And while movement will eventually help and it's recommended to move, it can be very difficult. And sometimes it takes almost all day of moving before they can finally get some residual kind of um, less severity when it comes to the pain and stuff. So that's kind of the main thing between this and osteoarthritis is that it takes movement to get it better, but it's going to take a while, especially if they're not on anti-inflammatory medications or they're not doing like an anti-inflammatory diet. And the other thing is that the features that we see with this are just not consistent with OA. It's going to be a younger population. OA is usually kind of 30 and over. These are usually 30 to 40. It's going to be in the wrong joints, and that OA likes to affect the more kind of distal toward the fingertips, and these ones are kind of closer to the wrist. The nodes that we talked about are going to be in different locations, and again, the hand deformities are going to be a little bit weird. So, we talked about kind of all this already, but different joints, especially the smaller joints, and it's usually going to be on both sides, whereas OA might be, on one side of the wrist or one side of the knee or, maybe kind of one spot in the spine. Rheumatoid tends to be fairly symmetrical or involve both sides. Also, rheumatoid usually does not like the spine too much. The really only exception is the neck, specifically closer to the head at C1, C2, but rest of the spine, very uncommon to have rheumatoid with it, whereas OA is fairly common, throughout the spine. But with rheumatoid, since it is kind of a systemic condition, it can technically involve any joints, but it still likes specific joints. And then rheumatoid will actually like the outer kind of toe joints, whereas OA prefers kind of the more closer midline joints, like your big toe. So that's kind of another distinction as well. If we're really thinking rheumatoid, we can also order blood work on these patients to look for specifically pro-inflammatory markers, is kind of what we refer to them as, but C-reactive protein or CRP, rheumatoid factor, and ESR is erythrocyte sedimentation rate. All of these are good indicators of an inflammatory arthritis. RF positive is suggestive of rheumatoid, but it's not an absolute because there's other things that can also come up as RF positive. And then anti-CCP, anti-circulating citrulated peptide, is also another thing that is very suggestive of rheumatoid, but it's not an absolute thing. But if you have all these abnormal in someone that has bilateral wrist pain and a 20-year-old female, that collectively is a fairly strong indication of rheumatoid arthritis. And then we can take x-rays and specifically look for those classic features of rheumatoid, which I have on this slide here. And the classic features that we see are just destruction of the joints, pretty much no joint space between it. Then we have these large erosive where it looks like there's holes within the bone as well. Some radiologists that first saw that is actually attributed it to and thought it looked like a rat bite. So these are sometimes, you might hear them referred to as rat bite erosions. And you'll notice is that There's a ton of destruction at the joints that where the finger meets the palm and at the wrist, but way out kind of by the actual fingertips, it's really actually not too bad. I mean, just look at the fingertip on the thumb here. It's not too bad at all. And that's something that you would see with OA, but you do not see with rheumatoid. So this is just a classic rheumatoid. And you'll notice it's on both hands and it's fairly the same from side to side, which is something that OA usually does not. And again, if we look at the knee x-ray here, we talk about how OA will usually involve one side of the knee and will cause narrowing on one side while a normal joint on the other, whereas rheumatoid will actually cause narrowing on both sides, whether it's in an adult and rheumatoid, or whether it's in a kid, in which case it's juvenile rheumatoid arthritis or JIA, or I'll talk about that on the next slide. But the main treatment or goal with rheumatoid is to prevent the rheumatoid from leading to this severe kind of deforming arthritis known as arthritis mutilans. And as you can imagine, this person is probably in severe pain and is unable to really do any of the normal activities, things like brushing your hair, excuse me, brushing your teeth, combing your hair, things like that. It'd be very difficult and painful for them to do. So we want to try and stop the progression of the disease while also giving the patient therapeutic relief. So again, it's going to require multiple physicians, especially if it's involving multiple locations like the eyes and the lungs and things like that. But conservative treatments have been shown to be effective, especially at reducing the severity of the flare-ups and the frequency of the flare-ups. And every patient's different, so it's trying to find the right combination of, is it acupuncture and massage with the drugs, or is it the curcumin with, the chiropractic adjustments with an anti-inflammatory diet. It's just all about finding the right mixture. But generally, exercise and trying to reduce the inflammation with the body are going to be the main things that are going to be the most beneficial to the patient. And then I have just a quick thing on JRA here. So JRA is kind of the old name, juvenile rheumatic or rheumatoid arthritis. And what happened is they would essentially, if a kid had someone that was too young to have rheumatoid had findings of rheumatoid, they would just call it JRA. And there's different subtypes and things like that that's beyond the scope of this presentation. But the other names that are kind of synonyms with JRA is kind of the old name. There's JCA, which is juvenile chronic arthritis, and JIA, which is juvenile idiopathic arthritis. All these are generally referred to as the same condition, where you have findings of rheumatoid just in a younger population than that 30 to 40-year-old female that we're thinking. Some subtypes of rheumatoid are almost exclusive to young females. Other types are almost exclusive to young males. Again, it's a very complex condition, but generally speaking, you're going to see findings of rheumatoid in the sense that there's going to be synovium thickening, there's going to be pannus formation, joint destruction, and it's more so in kids you have to worry about early fusion, because as kids are growing, if all of a sudden that joint fuses because of the inflammation, that joint cannot grow anymore, and they'll start to get discrepancies either in their limbs, or a lot of times JRA will affect the jaw, and they'll have a very, very small jaw, but the rest of their skull will keep growing and it'll produce like a very large overbite. Or a lot of times JRA will affect the cervical spine a lot more than rheumatoid. And if all that area fuses, then they can't move their neck at all. And essentially it won't even really grow too much either. So like with most conditions, you want to catch these as soon as you can so you avoid the fusion and the problems associated with it. Another interesting feature with JRA is that you're a lot more likely to see systemic kind of symptoms and conditions like an unexplained rash, an unexplained fever that comes back multiple times, or even just like a migrate, what they refer to as migrating joint pain, where first it'll be their hands hurt, then it'll be their elbows will hurt, then their knees will hurt. It seems like the joint pain is just going all over the place. Okay, so gout is another kind of important one. It's very common. And this one is a little bit different than the other two we talked about. And this one is primarily due to a poor diet and a kind of a sedentary lifestyle, especially in males. There are certain pathologic conditions that can cause hyperuricemia in the blood. But generally speaking, this is one of the more avoidable ones, I'll say, other than osteoarthritis, in the sense that if you have a good diet, you have a good kind of exercise routine, it's not likely you'll get this. That being said, patients can still get this because there are certain medications that can predispose to hyperuricemia that can lead to gout, or sometimes lead poisoning can also lead to gout as well. But the key thing with this one is that the main culprit here is uric acid. If there's too much uric acid in the blood, it starts to kind of diffuse out into the adjacent soft tissues where it forms crystals called monosodium urate. And the problem with those crystals is that the body senses that the crystals are there and it tries to eliminate the crystal by initiating an inflammatory response, which causes the redness, the swelling, and the pain. The problem is that monosodium urate crystals are very hard to destroy by the body. So the inflammation, which is only supposed to destroy the crystals, ends up destroying other areas around the crystals. And since a lot of times these like to be deposited near joints, it starts leading to joint destruction. And that's where we kind of see this association with, this hot, red, very, very painful joint. And a lot of times, if you do a blood test in these patients, you'll find that they have high uric acid levels in their blood. And some foods that are kind of notorious for leading to either high uric acid levels, or you have a patient with a history of gout that they eat the wrong food and then within a couple of days, bam, all of a sudden they have a gouty attack. Shellfish, meats, especially organ meats like liver and kidneys, alcohol consumption, and then sugary drinks like pop and soda. A lot of times if patients do have gout, if they eliminate most of these foods and then kind of favor other low purine type foods, and purines are basically a precursor used to make, it's a broad group of precursor that you can use to make uric acid. If you eliminate a lot of that, then the chance of having this kind of gouty type of inflammation is relatively low, among other things. So this is one of the ones that almost universally favors males. It can still happen in females, but if you look here, 20-to-1 male to female ratio, especially when you're 40 years old. The older you get, it tends to kind of become more equal between the sexes, but kind of middle-aged person, classically, it's going to be a male that gets gout. And like I talked about before, there are certain hereditary conditions where either the body is unable to dispose of the uric acid, even if it's normal levels, or the kidneys are unable to properly filter out the uric acid. But generally, it's due to there's just too much uric acid within the blood. And sometimes patients have kidney disease where, again, the levels themselves might be normal, but if the body can't get rid of them due to the kidney problems, then the uric acid levels are just going to grow and grow over time. So that's kind of another example of a non-dietary thing, but far and away, it's usually due to dietary problems that leads to the gouty formation. And a lot of times we'll talk about how the pain will actually begin, especially like there's a little ache in the middle of the night, but then it'll wake them up later in the middle of the night or early in the morning, and it'll just be red, swollen, excruciatingly painful, can like even barely walk on it. And that's kind of the interesting thing with this is that you never really notice how often you bend your big toe until you have a gouty attack, and then even minimal walking is just excruciatingly painful in patients that have this. And since this is a systemic condition, it can actually affect any joints, but there are specific joints that it loves, and kind of the big toe is the main one here. And when it occurs there, it's often known as podagra. But the different stages that gout will go through are classically described as this, where for whatever reason, there's high uric acid levels within the blood. And even in this stage, they can be very asymptomatic or have no problems whatsoever. But eventually, as we get more and more crystals depositing within the soft tissues, it'll eventually invoke that inflammatory response. And that'll essentially cause all that redness, swelling, and pain that we kind of classically think of when we think of that acute gouty attack. And then eventually, either through medication or diet modification, the attack can actually minimize and go away, in which case they're kind of in that intermediate or intercrucial gout stage where they're no longer having an attack, but then they can also re-exacerbate it months, weeks later, and now they're almost back to square one. And if the more and more attacks you have, it can eventually lead to a chronic tophaceous gout, where that's when you really start to see the joint destruction that we can see with X-ray, and it can again further cause damage to the kidneys and other problems within the body. So like I kind of talked about, the main joint we think of for this is the big toe. When it occurs here, it's known as podagra, but really any joint can be involved. Your hip joint, technically the spine could, but the big ones are the hands and the feet and the knee as well. The blood work that we can do will show hyperuricemia within the blood. That's kind of one of the giveaways. But then we can actually, not specifically us, but a rheumatologist can specifically stick a needle in there, pull some fluid out within the joint, and a lot of times they'll see these monosodium urate crystals, which to me always look like little spears. And again, it's not that the spears are poking around irritating things, it's just that the immune cells see the spears and try to destroy it, but it ends up destroying pretty much everything around it besides the spear. And the main thing they try and eliminate the possibility of is an infection, because this can look just like septic arthritis clinically. Painful, red, swollen joint in a middle-aged male that occurred unexplainably. Sometimes they can even have a fever incidentally that can really make you suspect like a septic arthritis. So if it's truly septic arthritis, when they do the aspiration, they won't see the crystals, they'll see the bacteria, and they can culture it and figure out what it is then. Also, with an infection, they won't have the hyperuricemia, but they might have pathogens within the blood itself. So main thing they try and work up with this is septic arthritis versus gout. And then here's some examples on x-rays here. And again, you can just see the amount of joint destruction within kind of the big toe here, where we have all these erosions everywhere. In fact, this one's actually starting to fuse because of just the chronic nature of the gout. And all this white stuff here is essentially part of that tophus that you can see with gout, where it's just kind of like a combination of inflammation, crystals, and just kind of bone deposition from all the inflammation. And it's affecting kind of whatever joint it wants to. So kind of here, a little bit further into the toe, and then it's affecting some of the smaller toes as well. So any joint can be affected with gout, but the big toe is the big one. And then you can also get it in the hands, and it can produce this characteristic, very like lumpy, bumpy hands. So a lot of times it's referred to as unofficially as a sort of lumpy, bumpy disease, but it's pretty classically seen, this appearance, especially if they have like severe untreated or undertreated gout. So key things we can do in terms of treating this are just like we talked about with rheumatoid, reducing the inflammation, and then more specifically trying to go for a low purine diet that's not going to produce as much uric acid. So things to avoid, what we talked about: shellfish, specific meats, especially organ meats like the liver, alcoholic beverages and soft drinks, where fruits, vegetables, some whole grains, low-fat dairy, legumes, nuts are going to be kind of more beneficial to not producing all this kind of precursor to make uric acid. But another common thing that we've learned about over the years that's been pretty effective is tart cherry juice, especially if they're in like an acute stage where it's like very, very severe. That's been shown to be beneficial. Increasing our water intake. And then, and I don't get any kickbacks from the curcumin company or anything like that. It's a very good supplement to recommend in someone's in an inflammatory state. Continual kidney monitoring again, just because the uric acid can also get deposited within the kidneys and cause problems there. Or a patient might have some other underlying kidney disease that will inhibit the body's ability to get rid of the uric acid, which could make the gout worse or prolong the actual kind of problems associated with it. And then pretty much any conservative therapy that's going to benefit the patient will be recommended, including acupuncture, adjusting, PT, cold packs, whatever we can do to kind of help get them through that acute gouty inflammation phase. And then CPPD, I'll kind of go over quick. Main thing with CPPD is that it stands for calcium pyrophosphate deposition disease. And this is something that can mimic gout, but it's not going to have the uric acid levels, and it's not going to have the specific kind of x-ray findings that we see with gout. So CPPD is going to produce kind of deposition of kind of calcium pyrophosphate crystals within soft tissues like the menisci within the knee. And this one is just so confusing for a lot of people because it's been called different names over the year and has a very wide presentation in terms of you have people that have this that have pretty much no symptoms or no problems whatsoever. But then you have other people that have it and they have severe secondary osteoarthritis from it, or they have severe inflammation that can mimic gout in terms of you have a hot, red, swollen, painful joint that you think gout or infection, but they do a joint aspiration. There's no monosodium urate crystals. There's no pathogens or bacteria within it, but they do have another type of crystal that looks kind of like a little square instead of a little spear, and that's the calcium pyrophosphate crystal. And again, these things can be notoriously tricky to figure out, and they can be pretty common. And as far as determining if it's actually causing the patient's problem, can be a little bit tricky as well, especially because it gets more common the older you get, like osteoarthritis. And there's debate whether it's the pain is actually just caused by the osteoarthritis or the pain is caused by the CPPD. But it's, again, it can be very tricky at times. And from an x-ray or an imaging standpoint, it looks just like osteoarthritis, but then you see all this extra kind of white stuff within the joint in an area where we'd expect soft tissues to be, namely at the knee here in the menisci. But you can also see it around the wrist in a specific structure within your wrist called your triangular fibrocartilage complex, or TFCC. But again, the main thing with this is that you don't misdiagnose it as gout or septic arthritis. And if you've cleared both of those, it's kind of a diagnosis of exclusion where, okay, it's probably CPPD. And again, kind of similar locations to gout in the sense that knee, ankle, sometimes the wrist, middle of the hand, although this can actually involve the cervical spine, not commonly, but on occasion it can. And if you look here, here's the actual crystal that you see, and it's not the little spears that we saw with gout, it's more kind of the square, rectangular, rhomboid sort of appearance. And again, sometimes you can see this actually within the neck, especially the upper cervical spine, in which case it's also known as Crown's Den syndrome, but not as commonly associated to cause neck pain as other things, but it's something to be on the lookout for. And you can also see this in and around the shoulder. There is another type of arthritis that can affect around the shoulder and cause joint pain called hydroxyapatite deposition, but that's kind of beyond the focus here. But you can see this in kind of weird locations, and whether they're actually causing pain or not, it can be somewhat of a debate depending on how the patient presents. But generally, if they're painful and they're presenting as kind of an inflammatory sort of patient, we'll basically recommend anti-inflammatory conservative therapies. Again, anti-inflammatory diet, curcumin, ice, hot packs, adjusting, whatever is beneficial to the patient. Whereas if they're asymptomatic, again, we're going to do kind of preventative osteoarthritis-like therapies, moving it as much as you can without overstressing the joint, adequate water intake. Sometimes we'll even recommend the chondroitin sulfate or the glucosamine as well, assuming they're not on blood thinners. All right, and then the last one we'll talk about here is ankylosing spondylitis. So this is one of the ones that can actually affect both synovial and non-synovial joints. So a lot of times we'll see this in the spine. And that's kind of an important thing to remember, is that this really loves the spine, but it really doesn't like the extremities. So ankylosing spondylitis in the hands or in the feet is not very common, whereas something like rheumatoid is a lot more common in the hands and the feet, less so in the spine. And the key thing is that this will affect not only back here in these synovial joints, it'll actually affect out front in the syndesmotic joints, which is the intervertebral disc and the vertebral bodies, which is unique. So the other name that you probably heard this referred to as is just simply AS, ankylosing spondylitis. There's a couple older names that I'm not going to go over because almost no one other than the person I used to work with called them that. This one, again, is hereditary in the sense that if you have a primary relative like a father, a brother, an uncle, a grandfather that had this condition, there's a risk factor for you developing it as well. But again, it could be multifactorial as well. Do you have some other underlying inflammatory condition in your body going on, like Crohn's disease, inflammatory bowel disease, or ulcerative colitis? All those are risk factors for potentially developing this. And much like rheumatoid, this can affect both joints and soft tissue structures like your lungs. So you have to kind of be aware of that as well, your lungs or your eyes. So depending on what's being involved, it might require additional physicians to kind of help co-manage the patient. And if it's mistreated properly or misdiagnosed, it will eventually lead to spinal fusion of the entire spine, but usually likes to start kind of in that lower back, kind of lower kind of pelvis area, and eventually it can actually involve the entire spine if it's not treated correctly. A lot of times if treated properly, it might only involve the low back. So key things with this one will, traditionally it's been referred to as like a 3-to-1 male to female ratio, especially younger males, 20 to 30. But now we're starting to see more evidence that females may also develop this. It just might not be as severe in females as males. And that's kind of a unique thing that We're still kind of undergoing further research to figure out why that is, because it's very unusual. Because usually it's females that end up being more symptomatic than males with a lot of different conditions. So that would be very interesting to find out. But for now, classically, males are more common. And like OA, in the sense, a lot of times patients will present as unexplained kind of stiffness or pain in the morning. But with OA, we talked about how if they move around relatively soon, eventually it'll go away. But with ankylosing spondylitis, like rheumatoid, maybe it'll go away, but it takes a lot of movement and it takes a while before you can actually start to feel better again as you move around. And it can be very painful just moving around until you kind of pass that threshold where it's a little bit easier. And generally, the stiffness in the morning will take longer and longer to specifically kind of rid the body of that stiffness and pain, and especially if they're not being treated appropriately for it. And like I said, it usually begins in the lower back and will kind of migrate its way up into the neck. But if you treat it appropriately, it shouldn't be a problem. And if we look at if we look at the diagram here, normally we have our vertebral body and the disc in between it, and that's fine. But what happens in patients with AS is they start getting inflammation, specifically kind of at the where the disc meets the vertebral body. And there's a ligament that runs in the front and a ligament that runs in the back here, where a lot of times they'll get inflammation around that ligament. And as the inflammation progresses, it can actually lead to deposition of bone, producing fusions. And as I'll show on the x-ray, this produces a classic appearance known as kind of a bamboo spine sort of appearance. And as far as the key locations, again, pretty much going to involve the spine, a little bit of the low back, especially where the spine meets the hips, known as the sacroiliac joint, maybe a little bit of the shoulders and the hips, ribs for sure. And in fact, as the fusion starts to occur within the ribs, that could limit the patient's ability to take deep breaths in and out. And that's kind of one of the early to mid findings of ankylosing spondylitis, is that there's a decrease in chest expansion. So as they go take a deep breath in, they can only breathe in so much because their entire thorax is fused. Whereas in patients without this, the ribs and the bones that make up your thorax tend to move a little bit as you breathe in and out. But the first spot we almost always see it, again, is the sacroiliac joint, where the spine meets the pelvis. And then from there, it'll go into the spine and it'll go up and down the spine. And then, like I said, the distal arms and distal legs, so toward the feet, toward the hands, very, very uncommon to get it there. We can also do pro-inflammatory markers in these patients as well, including ESR and CRP, which both should be elevated. And they're non-specific findings or markers, but they're good at telling us that something's going on within the body. RF, rheumatoid factor, will usually be negative in these patients, because if rheumatoid factor was positive, we have to start be thinking rheumatoid or one of the rheumatoid variants like lupus or Jacquard's that we didn't talk about for this other than rheumatoid. But the main blood test that's positive in these patients is HLA-B27. If HLA-B27 is positive, it's a good indicator to think they might have something in the ankylosing spondylitis family. There's 3 other conditions that can also mimic AS that we're not going to talk about, but it's a good clue to think AS or something like it. And AS, of those 4, AS is the most common. So that's why people attribute the HLA-B27 positive to the ankylosing spondylitis. And like with rheumatoid, this can affect different areas of the body, heart, lungs, stomach, urine, infertility. It can just be all over. So it's important to diagnose this as soon as we can and to treat it as soon as we can and get the appropriate co-management if indicated in these patients. But the x-rays will usually show classic features of AS, and if caught early enough, that's the best outcome for everyone. So here I got some x-rays for you, and if you look at kind of the gray x-rays here, that's what we normally expect our patients to look like, where we have our vertebral body and we have the disc in between it, which you can't really see the disc because with x-ray you can really only see bony structures, not soft tissue structures like your intervertebral disc, but you can see the space where the disc would be. And you can see that these bones are actually not these bones are not connected to each other, which is normal. Whereas over here, you can see that nice white line going all the way down in the front and a little bit in the back. And on the front, you can actually see it going down the side. And someone thought this looked like a piece of bamboo, where they have those little compartments within it. So it's referred to as a bamboo spine amongst radiologists. The other thing you can notice is that right here, these little kind of gray lines here, that's your sacroiliac joints. That's where your spine actually kind of meets and articulates with the rest of your hip and your pelvis. So this is the earliest involvement that we're going to see ankylosing spondylitis in. And if you compare these joints to these joints in this patient, you'll notice that they really don't have any joints here because the joints have entirely fused. And that's the earliest finding that we're going to see with patients with ankylosing spondylitis is kind of low back sacroiliac joint involvement, and then it's going to involve the lumbar spine. And as it's mistreated or not treated, it can actually go up all the way into the neck. So like we've talked about before, the sooner we can find this, the sooner we can diagnose it, the sooner we can help the patient. And I've seen patients like this before where they're not too far away from this guy where his entire spine is fused to the point where he can't even look his head up. So this is obviously a person that was either not treated appropriately or for whatever reason was not taking the correct medications. And as it goes, you start to lose your normal curves within your spine until basically you have just straight, thoracic and lumbar spine, and then your cervical spine or your neck spine will actually just kind of bend forward, and essentially you have to look down or look essentially more down the rest of your life. So goal obviously is to avoid this. And it's going to be, again, depending on the patient, it's going to be a combination of conservative things with, co-management with a rheumatologist, and then depending on if they have eye problems or lung problems or cardiac problems, we're going to co-manage with those patients as well. But movement is going to be the main thing to try and help avoiding the fusions, in addition to the anti-inflammatory medications, supplements, and diets as well. And then just, through the adjustment, actually getting things to move will also be beneficial as well. Acupuncture can be beneficial too. Okay, and here's my little cheat sheet I have for you. Feel free to pause for the recording. We're making a recording of this, by the way. Feel free to pause and kind of go over this as well. It's basically what I took within my PowerPoint and just made a nice little kind of table for everyone. Again, most of these are either going to prefer males or females. Sometimes it doesn't matter, like an OA and CPPD, but sometimes like an AS and gout actually prefers males. And then the age range is going to be a little bit different, again, depending on OA. The older you get, the more likely it is, whereas JA, JRA, or JCA is going to usually be younger populations. Joint involvement is going to be the big thing that can help us differentiate these. And then a lot of these will have normal lab findings, while other ones will have more specific findings of inflammatory arthritis, like rheumatoid and ankylosing spondylitis. X-rays are usually helpful in at least trying to get us on the right track, but X-rays in combination with blood work, in combination with other pertinent clinical information, is going to be the best way we can try and figure out what type of arthritis is going on here. So thank everyone for, watching this. And if you have any questions for me or for Dr. Jesse, please don't hesitate to stop in or just call and ask one of us. And, we'll do the best we can to try and get you on the right track. Because with most types of arthritis, the worst thing you can do is just kind of let it progress and let it get worse. The sooner we can figure out what's going on, the sooner we can get you the best treatment, and the happier everyone will be overall. So thank you and have a good night.